Hasnani ma'am, for conducting such a scientific session, Practical Diabetologist 2025. So I and Dr. Smruti sharing the same topics. That topic allocated to us discuss very rare in different scientific programs. And we are dealing with the topics. It has the huge burden, not only in globally, but more burden in India. It has the very huge implications, and we have the solution for that also. So today's topic that allocated to us is the pre-diabetes, burden, implications, and solutions. So this is the outlines of today's talk. What is the pre-diabetes? The burden of pre-diabetes in India and globally, the implications of pre-diabetes, the microvascular complications, macrovascular complications, risk of type 2 DM, lifestyle interventions, pharmacological interventions, and take-home message. So today we start this talk with a case. A female 38 years of age, pre-diabetes since 3 months. Parents have history of type 2 diabetes, history of GDM 3 years back, no on current medications and present to me for the diabetic assessment. This is the key vitals and laboratory test results of these patients. Blood pressure normal. BMI and HbA1c of alert mode, HbA1c of 6 on pre-diabetic range, BMI high. Creatinine, eGFR, urine ACR within normal range. And again the LDL, triglyceride and HDL and abnormal range. So, Dr. Smruti, what is the pre-diabetes and what is the burden in India and globally? Would you explain it?
Sure. I'll explain now what is pre-diabetes. You guys saw the case, remembered, it will come back. But for now, let's explain what pre-diabetes is. I'll put all three of these. Now, fasting plasma glucose in pre-diabetes is between 100 to 126. OGTT to our plasma glucose 140 to 200, and in HbA1c 5.7 to 6.5. These are the cutoffs for prediabetes. Now, global burden of prediabetes is rising at a very high pace. According to IDF, 541 million have impaired glucose tolerance tests in 2021, and it's rising. 537 million have diabetes in 2021. ADA expert panel says 70% people with prediabetes will convert to diabetes. More than 40 million people in India are with undiagnosed diabetes. 25.2 million Indians are pre-diabetic. ADA expert panel says 70% pre-diabetic will eventually develop diabetes, as I said before, and 5 to 10% pre-diabetic become diabetic every year. Now, progression to diabetes in South Asians is 12 to 18% a year, while in Europeans is 5 to 11%. So as you can see, in South Asians is much higher than even in Europeans. Now, I'll invite Dr. Dhrumil here to explain to us a bit about implications of prediabetes.
So, implications of prediabetes. As we see, the complications of the prediabetes already start in a cutoff value of prediabetic range, loss of the beta cell function, incretin effect, and the insulin sensitivity start in a prediabetic range. Also rise in postprandial glucose, fasting plasma glucose start in prediabetic, contributing to development of the macrovascular complications. But we know only the macrovascular complications is increase in prediabetic. But this diabetes prevention program also state the diabetic retinopathy, the microvascular complication also found in 8% of the pre-diabetic patient. And the rising burden of macrovascular complications in pre-diabetes. So impaired fasting glucose defined by the ADA range of 100 to 125. Here the risk of CVD in 53 prospective cohort study with almost more than 16 lakhs individuals of mean duration of 9.5 years of followed found more than increase 13% risk of the CVD, 10% risk of the CHD, 6% risk of the stroke, and overall 13% risk of the all-cause mortality in pre-diabetic range. And if we define IFG by the WHO guidelines, that cutoff of 110 to 125, the risk is further increasing. 26% risk of CVD, 18% risk of CHD, 17% risk of the stroke, and 30% risk of the all-cause mortality. And prediabetes is not as beginning as one thought. Here the study of the research articles correlates between the prediabetes and coronary artery disease severity in a patients undergoing the elective coronary angiography. The three different groups, Group A, Group B, and Group C. Group A is a normoglycemic range, Group B is the pre-diabetic range, and Group C is a diabetic range. And if we see the results, concluded the prediabetes is associated with the high atherosclerotic burden and coronary artery disease complexity that is like diabetes compared to the normoglycemic individual. And again, a study of total of 8 study, almost 10,975 patients with ischemic stroke or TIA and with information on pre-diabetic state were included. Another study, almost similar, found people with the prediabetes are more prone likely to suffer the stroke. So we can say now it's time to take actions.
Yes.
Again, back to our case. Just I am highlighting the key points. The BMI 31, HbA1c of 6, and abnormal lipid profile range. So, Dr. Smruti, what is your opinion in this case? How you go forward to get this case, either of lifestyle interventions or pharmacological interventions?
Okay, seeing that it is a new patient for us, they haven't had any lifestyle modifications, anything at all yet, I would go with lifestyle intervention first. Give them some time, to figure out maybe they can diet, exercise. We'll talk more about it, but yes, I would definitely go with lifestyle interventions. Let's look at this, DPP research group. The objective of this was, I'll take this, you can take this. Effectiveness of therapeutic lifestyle interventions and metformin in reducing the onset of type 2 diabetes in patients at risk of diabetes. This included patients or people with BMI greater than 24, FPG 95 to 125, and 2-hour post-prandial glucose is 140 to 199. It took around approximately 3,000 people. These were the results. Now, this is important. In these results, it shows placebo 28.9% converted to diabetes from pre-diabetes. With metformin, 21.7% converted, which is still less than the placebo. However, with intensive lifestyle changes, 14.4% only converted from pre-diabetes to diabetes. Lifestyle changes that we would like to accommodate for patients would be cut sugar and refined carbs from your diet, as we all know. We usually tell them to cut down on rice and potatoes. Exercise at least 30 minutes daily. I know this says most days, but we should tell them daily because patients don't always go daily. So at least if we can get them to do it as much as they can, it would be nice. Monitor blood sugar regularly at home. Lose 5 to 7% of their body weight and get tested and follow up with the doctor. These are the dietary recommendations from the ADA. ADA recommendations suggest these proportions for meals. 50% of the plate filled with non-starchy veggies and leafy greens. 25% with healthy carbs like whole grains, brown rice, quinoa. 25% with lean protein. If they are non-vegetarian, they can go for chicken, turkey, fish, or tofu. If they're vegetarian, we can have lentils, pulses, beans, legumes. And of course, tell them to avoid aerated beverages. Aerobic exercises. Exercising in general will be good. I would highly recommend, I think before we had a session on this, weight-bearing exercises are great. Aerobic exercises, physical activity that increases their heart rate, oxygen consumption, using large muscle groups in rhythmic or repetitive manner. Now, exercises. Pre-diabetes. Exercising pre-diabetes would increase their cardiovascular improvement, muscle strengthening, like we talked about, reduces inflammation, increases energy expenditure, and, of course, glycemic control. Now, let's get back to the case. BMI, the patient came to us again. BMI from 31, it stayed 31. HbA1c from 6.0, it went up to 6.2. Lipids, they're pretty much have decreased or stayed the same. So now, I would ask you, Dr. Dhrumil, what should the patient do next? Should we then put them on?
Even after the lifestyle interventions, ask patient to do the dietary recommendations, follow and exercise. Still, the HbA1c remains in the same range. So I would go with the pharmacological intervention. So now, what? We have the evidence, the pharmacotherapeutic interventions in pre-diabetic that delays progressions and onset to the diabetes. So we have the AAC 2023 recommendation for the pre-diabetic algorithm. So even after the lifestyle interventions include the nutrition, physical activity, sleep hygiene and healthy habits for the cardiovascular risk reductions. For the overweight and obesity, if present, goal to target more than 7 to 10% of the weight loss with GLP-1 receptor analogs and consider bariatric surgery as and when needed. And if no overweight and obesity, then goal to treat the dysglycemia with the metformin, pioglitazone and the acarbose. Again, the diabetes prevention program research group study, I just want to highlight the role of the metformin, 21.7% conversion rate from the normoglycemia from the pre-diabetes to the normoglycemia, and compared to the placebo here, the 28.9%. Lifestyle changes and treatment with the metformin both reduce the incidence of diabetes in persons at the higher risk. Again, the STOF NIDDM trials, international study on the efficacy of the glucosidase inhibitors to prevent type 2 diabetes in a population with impaired glucose tolerance. Here, the 714 patients with impaired glucose tolerance receive acarbose and 715 receive the placebo. And the concluded, the results, acarbose could be used either as an alternative or in addition to lifestyle to delay development of type 2 diabetes in patients with impaired glucose tolerance. Again, the original articles published in New England Journal of Medicine 2016, the pioglitazone after ischemic stroke or transient ischemic attack concluded the risk of stroke or MI was lower with pioglitazone than the placebo. Again, the ACT NOW study also concluded the same results. It's a randomized double-blind placebo-controlled study. Pioglitazone reduced the risk of conversion of impaired glucose tolerance to type 2 diabetes by 72%. And as we know, the interventions with the pharmacotherapy in pre-diabetic stage that delays the progression and onset of the diabetes by 3 to 4 years. Again, the SGLT2 inhibitors, we have the evidence with the dapagliflozin in DAPA CKD and DAPA HF trials. It's a pool analysis. Enroll more than 4,000 participants who had no previous diagnosis of diabetes, and the results showed dapagliflozin reduced new onset diabetes incidence by 1/3. So, Dr. Smruti, what is your opinion in newer molecules for diabetes prevention in pre-diabetes?
So this is an important topic, newer molecules. We all know there are newer molecules out there and a lot of debate around it. Now, there's a step 1, 3, and 4, changes in glucose metabolism and glycemic status with once a weekly subcutaneous semaglutide, 2.4 milligrams. This is a STEP program. I'll show you the results in the next slide. Basically, among the participant with baseline prediabetes, 68 weeks treatment with semaglutide versus placebo led to significant improvements in glucose metabolism and higher likelihood of normal glycemia. You can tell. If we see here, step 3, semaglutide 2.4, 51.8% were normal glycemic, 48.2% were pre-diabetic. And after 6 weeks of treatment, 89.5% became normal glycemic. And it's a very similar results in all 3 of these. So, liraglutide, it's not as effective, but liraglutide can reduce body weight, BMI, waist circumference, and HbA1c levels in individuals with prediabetes. Tirzepatide, same thing for obesity treatment and diabetes. 3 years of treatment with tirzepatide in persons with obesity and prediabetes resulted in substantial and sustained weight reduction and markedly lower risk of progression to type 2 diabetes than with the placebo. As you can see, even in this, the mean percentage range, change in body weight at 176 weeks with tirzepatide versus placebo, it's increased. And cumulative index with tirzepatide, it's lower than the placebo. So in summary, pre-diabetes increased its risk of diabetes as well as micro and macrovascular complications. Identification and aggressive treatment of pre-diabetes are mandatory. Intensive lifestyle management is the cornerstone. Metformin is the only pharmacological agent recommended for the prevention or postponement of type 2 diabetes. Acarbose, pioglitazone, GLP-1 RA, and SGLT2 inhibitors can be considered. Thank you.
Thank you.
Bill and